the regional collaborative care organizations. So this morning we're going to be talking a little bit about what a behavioral health organization is, what some of the services that are available through Medicaid benefits in terms of behavioral health are, and what some of the exceptions are. Hopefully you have picked up as you came in a resource sheet and a copy of the presentation, so you'll have something to take notes on, and I'll explain the resource sheet a little bit as we get started. I am a licensed professional counselor by trade, but currently my position is to go around and educate people about what these benefits are and especially how to access them for your clients. And let's see if we can get this to work here. Okay, you can change the slide, please. There we go. Let's talk first about what Medicaid is. Medicaid is health insurance. It's kind of an unusual program in that it's a federal-state partnership. Within a general set of federal guidelines, each state can set up their Medicaid program however they choose. How the state sets up its Medicaid program is what's referred to as the state plan. These state plans have to be approved by a federal agency called the Center for Medicare and Medicaid Services, often referred to as CMS. So some of what we'll be talking about today is unique to Colorado. The benefits we'll be talking about are not necessarily the same in every state because every state's program is slightly different. This program does have several different kinds of ways you can qualify for it. Most of them are income dependent, although there are several other criteria, for example, permanent disabilities and pregnancy. So there are several different ways to qualify for Medicaid. Next slide, please. It's always fun with technology. We tested the system earlier and it worked fine. Of course, that has nothing to do with whether it's going to work now that we're trying to do it. So,
excuse me a moment. Those of us on Zoom can't see any slides.
Yes, we're having a few technology problems, but if you can bear with me, I'm just going to talk through a few of these. Those of you in the room, you have a copy of the presentation, so you kind of know what the slides are. In 2010, the Affordable Care Act was passed, which allowed for an expansion of Medicaid eligibility. Colorado was one of 28 states to take advantage of this opportunity. Currently, there are 32 states, if you include the District of Columbia, that participate in Medicaid expansion. Due to that expansion, currently, there are over 1.3 million people in Colorado who do receive Medicaid benefits. That amounts to 1 in 5 adults in the state, and 1 in 3 children in the state of Colorado are covered by Medicaid benefits. According to the American Academy of Pediatrics, that makes Medicaid the largest single insurer of children in the state of Colorado. In June of 2016, Colorado followed a national trend in changing the name of its Medicaid program. Medicaid in Colorado is now called Health First Colorado. This was just a name change. There was no change in benefits, but if you hear people referring to Health First Colorado, that is Colorado's Medicaid system. So currently the biggest insurer of children in the state of Colorado, and that's why understanding Medicaid benefits is important. The Community Behavioral Health Program is the program that manages the behavioral health benefits for Medicaid. How this is set up is a behavioral health organization is an independent organization, can be comprised different ways, which contracts with the state to administer all of the behavioral health benefits for Medicaid for a particular area of the state. These contracts are generally put out to bid about once every 5 years. Any interested qualified organization can bid on these contracts. Currently, the organization that I work for, Beacon Health, is a partner in 2 of those 5 behavioral health organizations. So if the people in the room can look at the page which has which says the BHO is on the top. It has some functions of a BHO. The BHOs are responsible for a number of different things. One is that it's the BHO's responsibility to maintain a provider network to actually provide the behavioral health services. This network includes the local mental health center, but also includes independent private practitioners. So Medicaid members have a choice of where they go to receive their behavioral health services. They can go to any qualified, credentialed behavioral health provider. It is the BHO's responsibility to credential those providers. So we see that the providers have the appropriate licensing, the appropriate experience to actually deliver the services that they're delivering to our members. In addition, it's another function of the BHO to be able to do the authorizations for services. So when a person provides Medicaid behavioral health services, they don't bill the state, they bill the BHO. These BHOs also are responsible to see that providers are paid in an appropriate period of time, and there are standards set up for that. In addition, it's our responsibility to monitor the providers so that they are following all the Medicaid rules and regulations, and there are quite a few of them. We perform random chart audits to make sure that the providers, as well as the mental health centers, are actually providing the services they say they're providing and are meeting all the Medicaid credentialed responsibilities. So if you can look at the next page, and I do apologize to those people on the phone. Oh, good. We're on the slide that said Medicaid Behavioral Health Services, 5 service areas. Cool. All right, hopefully those of you on the phone can now see this. If you walk away with nothing other than this information, this is what I want your takeaway to be. The phone numbers you see on this slide are the toll-free numbers that each BHO operates 7 days a week, 24 hours a day for information and referral for Medicaid behavioral health services. So I'll talk a little bit about the Beacon Health Options BHOs because those are the ones I'm most familiar with. But those numbers are staffed by licensed clinicians as well as by clinical service assistants. People can call these numbers and get authorizations for services. They can get referrals to services. They can find out what services are available and get a multitude of different types of information any time of the day or night. In addition to these phone numbers, each BHO also has a website where you can find a lot of the same information so that if you prefer to do this via the internet, you can also do that via the internet. For the Beacon Health Options BHOs, we try to make the authorization process very simple. You don't have to call us for authorization. Providers can even go online and get that for the more common levels of care, such as outpatient treatment. Now, for inpatient treatment and the higher levels of care, you do have to call us, and that level of care has to be pre-authorized. But for the other levels of care, we try to make it as easy as possible. So these are numbers that you can call, that your clients can call to get the information they need day or night, 7 days a week. Next slide, please. This map shows the BHO areas. And the reason I like to show this map is if you see the large maroon area, that's Colorado Health Partnerships. That's the largest BHO that Beacon Health Options is involved with. It's about 73% of the land mass of the state, but far less than 73% of Medicaid membership. Contrast that with the small black area you see kind of in the middle of the map. That's the Denver metro area. Smallest BHO in terms of land mass, largest BHO in terms of membership. The reason I point that out is the situation that different BHOs have to deal with is very, very different depending on the BHO. So delivering services in rural and frontier counties is very different than delivering services in a metropolitan area. A little later this morning, you'll be hearing about some of the innovative programs we have to kind of deal with that situation. But the yellow area, by the way, is the other BHO that we're involved in. That's kind of the Northwest Denver area, Foothills Behavioral Health. Next slide, please. So I mentioned that each state has a state plan, a different way their Medicaid system is set up. The first thing you need to know about Colorado's Medicaid system is physical health care is completely separated from behavioral health care. Two separate systems. The number you see on this slide is the number you would call for information about medical or physical health care issues. The BHO numbers that I just provided are the numbers you would call for behavioral health information. So physical health separated from behavioral health. In addition to those being separated, it's a completely separate payment system. The physical healthcare system is what's called a fee-for-service system. Basically, providers who contract with Medicaid agree to provide a service for a certain set rate. On the other hand, the behavioral health system is more of a managed care system. In other words, the BHOs are given a certain amount of money for every Medicaid member in their region every month. This is referred to as a per member per month payment. And the BHO's job is to manage that money to provide all of the behavioral health services which are covered by Medicaid and are medically necessary for the population of people in their area who have Medicaid benefits. So completely different system. Just a side note, there are certain types of Medicaid which do not include behavioral health benefits. They tend to be, you know, kind of rare, but they are out there. For example, there's something called QMB Medicaid, which does not include behavioral health benefits. So I won't get into that because that's into the details, but what I want to mention to you is if you call the BHO number, they will be able to tell you which BHO a person is capitated to and whether or not they have behavioral health benefits. Now, since this is protected information, we can't give this information out to you unless you have some legal guardianship type relationship with the person, or if the person happens to be sitting in the same room with you, we will ask you to pass the phone to that person and give us permission to reveal that information. But it's important information to have because sometimes a person is capitated to a BHO which is not the BHO in the area they're physically in. This happens, for example, with foster kids. A foster kid maybe is from Denver but is placed in Colorado Springs. The BHO that where the area where the person is from is still responsible for payment. The important thing to remember is no matter where in Colorado that person is, they can receive behavioral health services. It's just important for the provider to be billing the correct BHO. So this does happen. It also happens, by the way, when people move. So if people move and they don't change their address in the system, then they're still capitated to the BHO in the area from which they moved. Does that make sense to people? Okay, so bottom line is, when in doubt, call those 800 numbers because the BHO will be able to tell you how to proceed to get services. Please don't ever think that a person who has Health First Colorado can't get services because they're in some other area. They always can get services. It's just a matter of arranging it correctly through the BHO. Next slide, please. So these are some of the services that are provided through Health First Colorado in terms of behavioral health. If you're talking about mental health services, it's pretty much anything you can think of. Inpatient treatment, outpatient treatment, psychiatrist visits, residential treatment, pretty much any kind of mental health service is covered. In terms of substance abuse services, here's where it gets a little complicated. The services listed on this slide are covered through Health First Colorado Medicaid. So in other words, your basic outpatient treatment for substance abuse, you know, seeing a counselor once or twice a week to talk about maintaining sobriety, that type of thing is covered. Social detox is covered. Medical detox in a hospital is not covered through Health First Colorado benefits. That does not mean that you can't get that service paid for. I told you it was going to get a little complicated. Most substance use services in Colorado are covered by organizations called managed service organizations. For those of you in the room, if you picked up one of these resource sheets, there is actually the first one on the list of websites is a website where you can find the managed service organization responsible for the area the member is from. So if you're looking for a substance use disorder service that is not covered by Medicaid, contact the managed service organization in your particular area. And this website listed on the sheet is where you can find that. And again, I'd like to mention that this is not like a federal Medicaid rule. This is just the way Colorado has chosen to set up its system. And there are certain reasons for that, which we're probably not going to have time to get into, but we'll have like 20 minutes for questions after this. So, if you want to discuss that, we can. Next slide, please. Medicaid has certain standards of care which all providers must adhere to. One of those standards of care is when a member calls for an initial service in a non-emergency situation, the provider is required by their contract with the BHO to give them an intake appointment within 7 days of that call. Now, I will put a little exception to this because this comes up all the time. That does not mean you can get to see a psychiatrist within 7 days. The reason for that is just we don't have enough psychiatrists. There's no fancy explanation for that. And again, you're going to hear about some ways we're kind of trying to deal with that situation. Most mental health centers, for example, when you call for initial appointment, they will ask you to see a therapist first because they want to evaluate what services are really necessary for that person. So that initial appointment has to be offered within 7 days. And I do emphasize the word offered. So if an appointment is offered and the client says, well, I can't make that appointment, I can make it a week from Tuesday, then that's on the client. The provider has fulfilled their responsibility. In addition, the provider is required to offer 3 services within the first 45 days in addition to that intake appointment. So a person should be able to see a provider a total of 4 times within the first 45 days of treatment. In addition to that, the service must be medically necessary. And there's an official Colorado definition of medical necessity, but basically it means the service must be needed to correct a behavioral health condition. Before I did this education and training thing, which I love, I was on those phones, those 24-hour lines that you had there. The example I like to use, one time I had a lady call me and she said, I have Medicaid, I've done my research, I know Medicaid covers inpatient psychiatric hospitalization. I want you to put me in a psychiatric hospital because my kids are driving me crazy. Being a parent, having raised 3 kids, I understand that. I didn't think I could prove to Medicaid that was a medically necessary reason to be an inpatient hospitalization. So we will evaluate whether that service seems to be medically necessary. The service also must be provided in the least restrictive setting that we can provide it in. So in other words, I can't put you in an inpatient hospitalization if you can be dealt with by parenting classes or by family therapy or things like that. Next slide, please. Here are some important exclusions, and this is where your resource sheet is going to come in handy too. The first thing you need to know is Medicaid is secondary to any other type of insurance. What that means is if a person has, let's say, Medicare and Medicaid, they must first seek services through their Medicare. If they have private insurance and Medicaid, they must first seek services through the private insurance. That does not mean they can't get things paid for by Medicaid. It does mean you have to go through your primary insurance first. Sometimes, for example, the primary insurance doesn't pay for certain services that Medicaid pays for, in which case that's fine. When the primary insurance denies that service, Medicaid can kick in at that point. Intellectual and developmental disabilities. Once again, the way Colorado has chosen to set up their system is funding for many types of substance abuse services, funding for services for intellectual and developmental disabilities is separate, and funding for other behavioral health services is in another system. So, intellectual and developmental disability services are handled by agencies called community-centered board. And once again, if you look at your resource sheet, you will see, it's actually like third from the bottom, a website where you can find the community-centered board, which is responsible for your particular area. If you are seeking services for intellectual and developmental disabilities, contact the community-centered board responsible for your particular community. An important point to remember is, if a person has an intellectual or developmental disability, that does not disqualify them to receive mental health services from Medicaid. You know, when the legislature set the system up this way, I'm sure it seemed very logical to them, but those of us who work in the real world know that developmental disabilities are not necessarily separate from psychiatric and mental health conditions. So a person might have a developmental disability and in addition, maybe let's say have bipolar disorder. In that case, Health First Colorado can pay for the treatment for the bipolar disorder, but not the treatment for the developmental disability. Okay, are you with me? I told you it would get complicated, so this is where it gets a little bit more complicated. Intellectual and developmental disabilities, community-centered boards. Substance abuse services, other than those few that I've mentioned, managed service organizations. Organic conditions by themselves. Once again, this is that line between medical services and behavioral health services. And once again, sounds like a clear line, but in the real world, oftentimes it's not that clear. For example, behavioral health problems as a result of a closed head injury, that's going to fall under physical health care services. Neuropsych testing may be a behavioral health services, or it may be a physical health services. It depends why you're doing the testing. When in doubt, call the toll-free number for your behavioral health organization, and they'll help you kind of sort that out. The important thing I want you to remember is, because a service is not covered by Health First Colorado, it doesn't mean you can't get that service. It does mean you have to know the correct organization to go to get that service funded. Okay, and here I have listed for you those services that the BHO does cover in terms of substance use disorder services. Medicaid members are required to get their services from a credentialed Medicaid provider. Medicaid has certain rules as to what type of credentialing a provider has to have. There is, by the way, a mechanism by which a person can, in exceptional circumstances, receive services from a non-Medicaid provider. These are referred to as single case agreements. So this happens when maybe there's a specialty that a person needs that's not available in network. We will do a contract with a provider for that one particular individual to provide that services. This comes up most commonly for us, at least, with eating disorders. Eating disorders tends to be a specialty, and if you're outside of the Denver metro area, there's not a whole lot of providers who provide that service. So we will arrange a single case agreement for that type of service if we don't have a provider in network. If there is a provider in network, you are required to use the in-network provider. Pretty similar to most insurances nowadays, where you have to go with the providers which are credentialed by them. Okay, next slide. Okay, and this is my friendly owl here. I don't know if you could tell he's an owl. But we have a few minutes now to be able to kind of discuss this, ask any questions that you have, and also just make any comments that you might have. This is not, in my opinion, and I work in the system, this is not the easiest system to understand. This is the way the system is set up here in Colorado, though, and I'm here to help you understand, because the bottom line is we want your clients to get the services they need. Whether we're responsible for providing them or not, we want to make sure that you get referred to the correct place to get those services provided. So, questions? Yes. Hi, Carolyn. Mhm.
So a lot of times the population may not feel comfortable like calling or asking these types of questions. Like it just seems like a very challenging road, right?
Mm-hmm.
So if, as a care coordinator, if I were to call, like they can't give me any information, like really the patient would have to do that.
Right. What I would do is have the patient in the room with you. Oh, I'm sorry. Thank you for reminding me of that. So the question is, sometimes people are uncomfortable calling and they may have a care manager who might be able to make that call for them. Can the care manager get the information? The care manager can call the BHO and get the information, but they have to either have a release of information from the person or preferably have the person right there with you so that you can put them on the line and say, yes, I give you permission to be able to give this information to my care manager. Okay, and I'm fine with repeating the question. The question is, are there significant hold times when you call? And I'm glad you asked that question because I kind of mentioned Medicaid has a lot of rules. We have to submit a report to the state every month telling them what the average time is between when a person calls and when we answer the phone. And we have to try to do that within 90 seconds. So we usually accomplish that about 90% of the time. So there are very strict rules in terms of that. And I wish the rule was the same for everyone because I've called organizations that have been on hold for a long time. But you shouldn't be on hold very long at all. No. You're welcome. Mm-hmm. Okay. The question is the process for approval of services typically not covered. If a service is not covered in the state plan, we can't provide the service. However, there's always exceptions to everything. There is a section in Medicaid called EPSDT, Early and Periodic Screening, Diagnostic, and Treatment. For any Medicaid member under the age of 21, if a service is possible to be covered by Medicaid, even if it's not in the state plan, Medicaid has to be able to provide that service. So there are kind of special benefits for people under 21. Now, if you are 21 and over and the service is not in the state plan, it's not going to be covered by Medicaid. But again, if you call the BHO number, the BHO should help you, direct you to resources to help provide that service, even if it's not covered in the state plan. Now, in terms of providers, though, if a service is covered in the state plan, but we don't have a provider to provide that service, we can do a single case agreement, as I mentioned before. So that is possible, and those go through a person who is called our clinical peer advisor. For us, that's Dr. Steve Cohen. So he reviews those requests to see whether or not they are appropriate. But the bottom line answer to the question is, if it's not in the state plan, we can't cover it. Technically, that would be Medicaid fraud. And I think this is a term that people frequently don't understand. Many times when you read articles about Medicaid fraud, it's not that someone is billing for a service they didn't provide. Sometimes that does happen, but frequently it's someone's billing for a service they did provide, but it's not a covered service.
I'm the person who asked the question, and I just wanted to clarify. Earlier in the slides, you actually said just because it's not there doesn't mean it can't be covered. So I wasn't talking about something that is outside the plan. I was just trying to get more information of what you said earlier. If it takes, I mean, for sometimes like for pre-authorizations, for commercial insurance, is that the same kind of system?
Well, if a service is not in the state plan, it may be covered by another agency. For example, substance abuse services which are not in the state plan for Health First Colorado may be covered by your managed service organization. And if you call the BHO, you should not hear, and if you hear this, you're welcome to call me, you should not hear, we don't do that, good luck, goodbye. You should hear, that's not covered under Health First Colorado. However, here's the number to your managed service organization where that service may be covered. So what I meant when I said that is that those services may be covered by other resources other than Health First Colorado. Yes?
Could you say a little bit more about the relationship between Beacon and your partners, the Health First, or rather Colorado Health Partnership or the other partners?
Sure. Each BHO is set up differently. Beacon Health works on a partnership model. So for example, Colorado Health Partnerships, which is our largest BHO, is actually a partnership between Beacon Health Option and the 8 mental health centers that serve that area. So Beacon is what's called the administrative partner. There are a lot of requirements from the state, requirements that we submit reports, what percentage of people actually got in within 7 days, what percentage of people were seen 4 times within 45 days, you know, many of these things. So we provide all those reports to the state. We credential the providers. We maintain the provider network. We do the billing and payment. The mental health centers actually are the direct service providers. So Beacon Health Option is not a direct service provider. We provide all those ancillary services that are required in the contract. Now that's the way Colorado Health Partnerships is set up. That's not necessarily the way other BHOs are set up. You don't have to be a partnership to be a BHO. You can set it up however you want, and then you send your proposals to the state and they say yes or no. By the way, it just so happens that those contracts are coming up for renewal right during this period of time. So the request for proposal is expected to be out by May of this year. The system I've just described to you is changing fairly dramatically with the next round of contracts. Those contracts began on July 1st of 2018. Colorado, like most of the nation, is moving to an integrated care system where behavioral health services are not so separated out from physical health care services. So in the next iteration of what we've talked about as behavioral health organizations, there will be many physical health services also administered by those agencies. They will no longer be called behavioral health organizations. So what I've just said to you is knowledge that's good for about 16 months. You'll have to have me back in 16 months, and then we'll know a little bit about what the new system will be. But the new system, I am hoping, and I personally think this is a good idea, it won't be as complicated as what I've just described. A lot of those services will be merged into what are going to be called regional accountable entities, or RAEs. So physical health care services will not be so separated from behavioral health services. Yeah.
We have another question from online. So earlier in the discussion, you mentioned having a choice regarding providers. In the Southwest, we have only one organization that takes Medicaid. Their appointments are booked out 2 to 3 months for anything other than crisis care. Their employee turnover is large, and there are lots of complaints about quality of service. Unfortunately, there is no other choice here in the rural or frontier West. Do you have any thoughts?
Yes, I will admit in the rural areas that's true because, excuse me, there's a very limited amount of providers available. However, we do have private providers in all the areas of the state. Now, if you're living in a rural area, if you want a private provider rather than, let's say, the mental health center, it's possible you may have to travel a distance to do that. And that's just a result of the fact that for whatever reason, behavioral health tends to be a pretty urban profession. The practitioners tend to be concentrated in the urban areas. The mental health centers are required to provide those services in their area, regardless of whether it's rural or urban. However, again, the travel distance may be farther than you'd like to do. So it's definitely true in the rural areas. There's a little bit less availability. And in a few minutes later this morning, you're going to hear about some of the innovative programs that we have to try to help deal with that shortage, because we are kind of, I don't want to use the word experimenting, but we're trying new things to be able to deliver services to people in a more efficient manner who maybe are in areas where it's a little bit more difficult to get services. If you have complaints about the services that you are receiving under Health First Colorado, there is a state ombudsman whom you can go to. There is also, by the way, at your BHO, you can call that 1-800 number and ask to speak to the grievance coordinator. And we get these grievances. It's another report we have to submit to the state. We have to tell them how many grievances we got and how they were resolved. So if you have complaints about the services you're getting, please call the BHO and ask to have that complaint heard. There is a formal process to do that. And I would encourage you to do that. If you are denied services, please remember that under Health First Colorado, you always have the right to appeal. So if you want psychiatric hospitalization and you're told, no, that's not medically necessary, you can appeal that decision. And please, use your rights of appeal, use your grievance rights. They're there for you. The bottom line is getting the customer what they want. Yeah.
We've got one more question from online, asking, does Health First Colorado allow teletherapy services?
We have the person to answer that question right here.
Beautiful.
And actually, she's going to be talking to you a little bit later this morning. So I will give you an advanced sneak preview. Yes, one of the programs that we have that we are trying out is therapy through texting. And I'm not going to say too much about that because Sheba, who's going to talk in just a few minutes, is going to explain that program.
Right.
So I won't say anything more about that. I think it's a very exciting program, and I think she'll tell you we've had some, to me, surprisingly good results with that. And the reason I say that, for those of you on the phone, I've been practicing for over 25 years, so I'm not the youngest person in the room. When I heard about the idea of therapy through texting, I thought, well, how is that going to work? But it does seem like there is a large group of people who actually seems more comfortable doing therapy through texting than in a face-to-face way. So I'm not going to say anything more because Sheba's going to talk about that. All right. Other questions, comments? Yes, ma'am. Yeah, I did cover it. I'm sorry. No, I didn't. Yeah. Yeah, the question is dealing with dual diagnosis, substance use, and mental health problems. I'm going to be honest with you, the substance use services right now are kind of bifurcated. In other words, there are certain services that are covered by Health First Colorado, but they're very limited, and you'll see them in your slides there. All the other services, if they are covered by either fee-for-service Medicaid or by the managed service organization for your area. So it is kind of complicated right now. Outpatient services, regular routine counseling, Health First Colorado will cover. Inpatient detox, Health First Colorado will not cover. So it's a little bit complicated, but when in doubt, please call your BHO and we'll be happy to explain to you this is covered, this is not covered, this may be covered by your managed service organization. Mm-hmm. Yeah. Yeah, so the comment is, the questioner comes from a state where dual diagnosis are covered by Medicaid, but in Colorado, they are not necessarily, and are things moving in that direction? The short answer to that question is yes, they are moving in that direction. Prior to July 1st of 2014, no substance use services were covered by Health First Colorado. And then the ones we've just talked about were added on July 1st of 2014. Yes, I see us moving to a more integrated system where there's not so much siloed funding sources. And it does vary state by state, because every state sets up what's called their state plan. And as long as it complies with the federal regulations, those state plans can vary. And Colorado has chosen to separate those funding streams out for whatever reason. And I think my time is just about up. So I'd like to thank you for your patience and for your understanding. And if you do have questions, once again, I would just like to say, please do not hesitate to call your BHO and ask. That's what we're there for. Thank you very much.
My name is Heather Colwell. I work with Creo, which is one of the health information exchanges in Colorado. Can you not hear me better? I'd like to introduce my colleague, Toria Thompson. She's a behavioral health information exchange coordinator with Creo, and she has a really interesting presentation to talk to you about a consent pilot that we're working on at Creo.
While the slides are getting loaded, I'm just curious who's in the room. So how many folks here are providers working at provider organizations, whether you're a physician or a nurse or a care manager, somebody that's providing service level work? Great. How many folks are from an FQHC, a federally qualified health clinic? Got it. All right. And how many folks, I saw it, an inpatient hospital, psychiatric hospital, or, okay, how about inpatient non-psychiatric hospital? Any other hospitals represented here today? Okay. What other organizations? I didn't see some hands go up, so who am I missing? Public health, wonderful. Okay, good. Arico, all right. Oh, great, okay. Another inpatient hospital, okay. Which one?
The Regional Health Connectors.
Yeah, on the phone?
You're missing the Regional Health Connectors. There's a couple of us here too, attending by Zoom.
Oh, great, okay, wonderful. Nursing homes, of course, thank you. Yeah, good. So how many folks see patients that have either a mental illness or a substance use disorder coming through your organizations? All right, so quite a number of folks. And on the phone, I guess it's harder to get answers from people on the phone, but I'm seeing about half the people here are familiar with working with those who have a mental illness and or a substance use disorder. And then the other half perhaps have some questions about that. So I'm gonna try to gear what I'm saying that hopefully it will match what it is that you're interested in hearing, but I'm looking forward to the questions as well. So my background just a little bit, I actually am a software engineer by training, and about 10 years ago was hired by Mental Health Partners, which is the mental health center in Boulder that serves that region, as their CIO. And that's where I got the dunking in the mental health world. Those of you that work in that world, it is an incredible world of acronyms. And just as our previous speaker said, it is about exceptions, right? The mental health and behavioral health, not just in payment, but in treatment. It is an incredible, complex arena for those of you that I'm seeing some heads nodding around it. And one of the things that's interesting is that it's an exact same service. So I can go, for example, to, let's say, a FQHC, a federally qualified health clinic, that has an integrated care practice. So they have hired a mental health specialist, and I can go there and I can get my diabetes managed, and I can go there for regular therapy for my depression. And that is all outside the purview of mental health and substance use treatment services as regulated by the Office of Behavioral Health, it could all be fee for service through Health First Colorado. All of those services could make their way just through the physical health world of reimbursement. The way that I chart that in the electronic health record has to comply with physical health regulations, which are much less stringent than behavioral health. So the service that a patient receives at a particular hospital or clinic, it depends on who's providing the service often in terms of how that service needs to be charted, needs to be put into an electronic health record, how that information can even be shared. So let's say that, again, I'm a patient at a federally qualified health clinic, and I'm getting both depression services, but I'm also getting some diabetes services. And let's say I go and break my leg and the orthopedist needs to see my records. They might see that I'm seeing this provider for depression. And there's nothing regulatory-wise or otherwise that would prevent that, because HIPAA allows the exchange of treatment records among healthcare providers. However, if I go to a community mental health center and I receive my depression services there, let's say I go to Mental Health Center of Denver, and I get my depression services there, but I get my diabetes services at MCPN, Metro Community Provider Network, and I break my leg, the orthopedist is only going to see my physical health records, because the Mental Health Center of Denver is under the umbrella of a whole lot of different regulations, because they are a community provider of mental health and substance use treatment services. So as a patient, I've received exactly the same services in both scenarios, but how my record of health can travel from provider to provider, the kinds of information documented and what the different providers are beholden to changes depending on where I got my service. So it's an odd system, to say the least. So what we're seeing happening in the health information exchange world, which I'll explain in a moment, is how much benefit there is when a treating provider can see the full picture of somebody's health, right? So I'm not just seeing what I've given in terms of treatment. Let's take a nursing home. Let's say a person was in the hospital, received treatment, came out, and is now in long-term post-acute care. It is often difficult to know, and let's say prior to that they were receiving services somewhere else. One of the things I know is such a challenge at those long-term post-acute care, the nursing homes, is trying to go back in history and find all of the records for that person in all of the places of treatment. So a health information exchange is one way that can be beneficial, because what we do is we pull the records in from all of the different places where people receive treatment, and we create a consolidated community health record. But we can't do that for mental health and behavioral health services because of all the different ways those are regulated. So that's what I want to talk with you about, is kind of like that, tread a little bit lightly into this world and hopefully explain just enough of the nuances of that so that you can understand how you can get the kind of information that you'll need in order to be able to treat the patients you see fully, so that if they are getting mental health or substance use services, your providers can have that information so that they can talk to the person as a full person and understand the full issues. Okay, so I'm just going to do my slide presentation. If you can run to the next slide. Thank you. And again, so just real quick about who CORHIO is. It stands for the Colorado Regional Health Information Organization. And we cover this blue service area map. There's another HIE on the western slope called Quality Health Network. Next slide. Some information about CORHIO. We've been around since 2008. Next slide. And what I already explained a little bit. So if you're over here sitting in a hospital or a federally qualified health clinic or a primary care practice or a nursing home, you are often working with a lot of entities out of your office and faxing paper back and forth, receiving paper back in. And what a health information exchange is meant to do is to say, well, let's take all of these partners that everybody interacts with, and if they send us at CORHIO their data, then when the person at the center here uses our system, they'll already get the full picture of care. So that's really all a health information exchange is it just takes all of the electronic records, it matches them up. So we have a patient matching algorithm that looks at demographic data. So we know that Toria Thompson, who received services here, is the same Toria Thompson there. And we create a community health record at the center that allows providers, without having to fax and request, see that consolidated record. Next page. So this is a slide that builds. I'll just keep asking you to click as it builds. So just to give you the graphic. So right now we have most of the hospital data for that catchment area coming in. So if a patient of yours was seen at most of the hospitals in the Denver metro and that wider area, we have their ER reports, their inpatient summaries, their discharge summaries. We have those within seconds of them being placed into the EHRs. And keep on going. We also do some work with public health where we bring in immunization data and send that to public health. We also receive newborn screening data from public health. We get laboratory data. So if your patient goes out and goes to Quest or LabCorp or any of the laboratories and gets lab work done within seconds, that's available in our community health record. Radiology reports, not the actual images, but the written dictated reports. And also some of the information from what we're calling ambulatory and long-term post-acute care. So when a patient goes to a clinic, perhaps some of your clinics, we're receiving that information. So again, you could, as a provider, if you keep clicking here, the idea is that that creates a consolidated record. You can search for your patients here, and then you can see that global listing of that patient. Next slide. We also do, in addition to having a portal that people can log into, we also push results directly. So let's say that your patient goes out and gets a lab somewhere at LabCorp or Quest. We can push that lab result directly into your electronic health record. Likewise, if your patient ends up in the emergency room, we can push that emergency room summary directly into your electronic health record. The next time that you or a provider gets into that system, they will see that. So nobody had to request it from anybody. A little bit about us, as I said, we've got many hospitals connected. We're working with 11 more. The biggest hospital that's not connected yet is Denver Health, but all of the others are. We have 4,300 organizations, about almost 10,000 users using that system, and about 4 million patients are identified in our health information exchange. So let's take a look, because my specialty is in the behavioral health area. So if we look at, so far I've only mentioned physical health data, as you'll notice. So click again. So one of the reasons why we have this different sort of way of having to treat mental health and substance use disorder data. And by the way, the word behavioral health was an umbrella term that was coined because people got tired of saying mental health and substance use disorder treatment services. And so they said, let's just call it behavioral health. So when you see the word behavioral health, it means both mental health and substance use disorder treatment. Prior to 2011, there was a statute, and this was in the, I think, the DORA regulations, where it was a regulation that governed people with particular licensure. So if you were a mental health professional and you were licensed in the state of Colorado, this regulation prior to 2011 said that you had to get a release of information before you could share anything about your patient. So any kind of mental health information, substance use information, you had to get a release. A number of organizations created a change to that regulation, which was adopted in 2011, which said, if it has to do with mental health information, that should be treated on par with any physical health condition. That is as important for a provider to know that you have depression as it is for them to know that you have diabetes. And so after 2011, those professionals could now talk about a patient's mental health issues without needing to get a release. Why that's important is because HIPAA, which is the regulation which allows providers to see treatment data without the need for patient consent, now HIPAA could apply. So let's say that a patient comes to you and you have not seen them before, but you know that they have received services at a number, they tell you the organizations that they've gotten services from, and one of them is a mental health center. You could request records from that mental health center and see those records in advance of them coming to see you so that you could see their whole picture. And you wouldn't have to first get their consent, because often the patient hasn't even come into your office yet. So how are you going to reach out and get consent? So that's one of the beauties of this change, is it allowed mental health data. If you click again. So what it does say is that you can share mental health data under the guidance of HIPAA using the same protections as the guidance for the exchange of physical health. And click again. So what that did after 2011 is it allowed it, and this should say mental health information, it allowed mental health information to be shared under HIPAA, but there are still exceptions of information that can't be. So any notes that are taken during a treatment session, the specifics of what is talked about is absolutely not able to be exchanged, not only because of this regulation locally in the state, but also HIPAA does not allow those kinds of treatment notes exchanged. Substance use data, there's another federal statute. It goes by the name 42 CFR Part 2. How many people are familiar with 42? Okay, so 42 CFR Part 2 is a federal statute. It trumps our state regulation, and it says that if somebody is getting substance use disorder treatment, you have to get a release. They have to tell you it's okay to disclose their information. If they don't tell you it's okay, you can't. And one of the nuances here, and this is a kind of it's taken me a year or more to kind of figure this out. The 17 community mental health centers in Colorado, who have all had electronic health records well before 2011, right? They've all had them for a decade or more. Because prior to 2011, they needed a release for anything, there was no reason for them to segment the data in their electronic health records. Because in the state of Colorado, you had to get a release, whether it was mental health or because of the federal statute. So those electronic health records were created that the entire record was behind a wall that you could only get to with release. So just because the state statute changed doesn't mean anything changed in electronic health records. So the 17 mental health centers in Colorado, there are only one that I know will release mental health data without a consent. The others say it would take millions of dollars for us to change our whole systems so that we could kind of pull out the mental health data separate from the substance use treatment data and then disclose the mental health data. So in effect, although that regulation changed, most mental health centers are still considering 100% of their clients covered under 42 CFR Part 2. So just like when you call a BHO and you say, hey, does this person get services here, or can you tell me if this person is in your catchment area? They can't even tell you the identity of somebody because they are holding themselves out to be beholden to 42 CFR Part 2. You have to have that consent. So sometimes this can be confounding because as a provider, you're calling a mental health center, you're wanting to be helpful and go, hey, I really want to know like all the psychiatric medication somebody's on because could be really important. There could be drug interactions. And you get sort of the, sorry, I can't even confirm that they're a patient here. And so then you have to wait for them to come in for their first appointment, then you have to have them sign a consent form, then you have to fax that over. By the time you get the background information on the medications or whatever else that you need, possibly several treatments have happened. You might have already prescribed some data. So it becomes difficult. How many people in the room are part of, the organizations that they're part of are doing integrated care? And so there's a bit of that. So the idea here is we're really coming into the notion here in Colorado that you can't, just as our speaker said, you can't separate somebody's mental health issues from their substance use treatment issues. It's not as though you can just draw a line in any of us to say that this anxiety disorder is causing this heart murmur, or this heart murmur is causing an anxiety disorder. Yeah. So, okay. So what we have come to in Colorado is this notion of let's just provide full person care. But if that full person care means that that person is getting some of their care in a different facility, then we have this issue of getting the records. So I'm going to share with you a pilot that we're doing in CoRio to try to help bring the behavioral health data into that full community health record. And click again. This is a partnership with the Mental Health Center of Denver. We're also working with Signal Behavioral Health. Our back-end infrastructure is with a company called FEI Systems. They have a product that we're calling Choose to Share. Click again. So we already saw this picture. This is all the physical health data. We are now putting Mental Health Center of Denver data in a separate place, so separating it out because of the 42 CFR regulations. And in the middle, we're putting a patient-facing portal where the patient can say, it's okay for my provider to see my Mental Health Center of Denver data. Let's look at it a little closer. Click again. So, and this is one where you'll click through until it, yeah. So the client goes into an online portal, and at Mental Health Center of Denver, they're going to use peer support specialists, which are patients who have already received a certain level of recovery, to actually work with patients and educate them. We hope this will roll out in 2 weeks. So they'd say, yep, Mental Health Center of Denver data, and we're partnering with Bruner Family Medicine to start with, and hopefully Rocky Mountain Pediatrics. But of course, if this is successful, we'll roll it out to all the providers. And then that they're going to share all my information, and the purposes of use is for healthcare treatment and for this period of time. And then click again. And this is a release of information compliant with the state and federal regulations. The patient clicks a box down here. They retype in the password that they got into the portal through, and then that becomes an actionable consent. Now the providers, click again, will go into what I remember I mentioned, our community health record. It's our provider portal. They'll log in here. We have about 10,000 providers using it today. And they'll click on this Documents tab, and it will look at that consent. And if that provider is from Bruner Family Medicine, they will see a Mental Health Center of Denver continuity of care document, which will contain medications, allergies, the last treatments that the person had, their diagnosis, and so on. And click again. So there's a video I want to try to see if we can play. We had difficulty doing it earlier. We've got it playing. We're going to have it playing, I think, back there once we get ready. This is the patient education video that we've designed for this product, so that patients in the waiting room can take a look at this. And this is we might not be able to actually hear it. So in that case, I'll just give you guys the link and you can look at it on your own. But if we can hear it, it'd be fun. Do you want to, is it make host that you have to do there? Or? Okay. Oh, yeah.
All right. Oh, sorry.
People say they tell their doctors everything. Well, they're mostly right. The one thing that isn't shared with me often enough is all of their health information. I'm talking about your mental health and well-being, substance use, medical history, lab work, allergies, and medications you might be taking. It's important for me to know all the pieces that make up your healthcare picture. Did you know a third of people with a physical health condition also experience a behavioral health condition? It's true. I've seen the difference it makes when I know the whole picture of what's going on with you.
That's why I recommend Choose to Share. Choose to Share is a website where you provide and manage your consent to share your healthcare information with doctors and counselors. Choose to Share helps you safely connect with me, your counselor, and other doctors in your life to get the whole picture of what's going on with you. Choose to Share makes it easier than ever to take care of you. It lets your doctor know what medications you're taking and what effects they may have on your physical health. Some medications do interact with each other. Doctors need to know what they can prescribe to you that's safe with what you're already taking. Don't worry, not everything is shared. For example, any conversations you had with me, those stay private. Choose to Share lets your counselors and doctors work together to be part of your personal healthcare team. This platform is designed to make the overall process of sharing your healthcare information easier. How many times have you heard, because you're a new patient here, we're going to need your current records?
I can't tell you how many times I've said those words to a new patient. And we all know that process takes time. It gets old, and it's not fun for any of us, especially you with your busy schedule. I know how frustrating it is when sharing your healthcare information isn't as easy as it should be. You need a better solution.
Choose to Share means your healthcare professionals get the right information the first time. Choose to Share allows you to choose who you share your information with safely, securely, and without any headache. It's a smarter way for us to serve you, and it keeps your information private.
I like keeping my health information safe. It's mine. With Choose to Share, I have peace of mind knowing I can share my health information safely with the right people. It's easy. Talk to your counselor and they will get you connected to Choose to Share. And just like that, my doctor and counselor have access to the right information while keeping my privacy, well, private. I can log in at any time to add or remove who has access to the information I choose to share. It means I'm still in control of my information, and you can be too. Your health information, it's personal, it's unique, it's yours. It should be yours to control. And now that's possible with Choose to Share. Connect your care.
Thank you. Do we have time still for some questions? All right. Yes, in the back.
In addition, and for psychology services, what individuals could you share? Content is not. Are there then two special records?
Good. So the question is, other than the psychology notes, what other, other than medications and diagnosis, what is shared? Are there other contents of the record that can't be shared? So when I was the IT director at Mental Health Partners, we asked all of our clinical staff to stop taking notes in the electronic health record about the session. That if they were going to jot down notes for themselves to be able to track the progress of this person's story, that they had to do that in separate pieces of paper that they kept locked in a file drawer, and that the electronic health record was only for information that pertained to that person's specific treatment, none of the details of their life. So in that way, what we did, at least at Mental Health Partners, was to try to make sure that anything in the electronic health record would fall within the purview of something that could be shared. So these psychiatric or psychological notes would be kept on paper. Now, I don't know if that's the same practice across all mental health centers, but just like with a physical health EHR, there's not a lot of room to put your impressions, to type things in. A lot of it is just filled in, and that's really where behavioral health electronic health records are as well. So the information that can be shared is the date the person saw somebody, who they saw, what kind of treatment they received, a care plan, what their care plan is, and how far along they are in recovery, the information about assessments that they've received, allergies, those kinds of things. So really, pretty much, if the behavioral health center is stopping the practice of putting in those kinds of notes, anything in the EHR could be shared. Oops, sorry, say again. So nursing homes wouldn't be beholden to the same 42 CFR Part 2. They would have other regulations, and so they probably keep a lot more detailed notes on a person. But those, so let's say that there's a psychologist working at a nursing home. HIPAA would say that the psychologist's notes could not be exchanged. So if somebody asked the nursing home for their records, those psychological notes could not be shared. Now that's a HIPAA requirement, not a 42 CFR. So yes, in the case of HIPAA, that would be. Yeah. Go ahead. Great. You should be up here teaching. Go ahead. Go ahead. Yep. Oh, goodness. Yeah. Thank you. Can I give you the mic just so everybody can hear, and that way we're
So we're still stuck in a really gray area. There was a good article on ethics about documentation in the journal of, it's the CFHA journal, Family Systems and Health, in 2013 that actually states as of 2013, there has never been any case law, any challenges to people openly sharing information in a record.
You have to go.
Okay, so there's been no challenges yet, but it's still very gray, even if you try to follow what HIPAA says can be included. My question for you is, I still feel like we need to have a better guidance on policy, or how organizations can establish policy around how to protect themselves on this. Have you guys thought about that at all?
Can you give the definition of what HIPAA says around a psychological, whatever?
I can try. So HIPAA designates what a psychotherapy note is versus what can be included in the medical record. HIPAA clearly says you cannot include a psychotherapy note in the medical record openly. They say a psychotherapy note is, and I cannot quote the exact definition, but generally the contents of a session that are analyzed by the therapist. So as a psychologist, back in the day when I wasn't doing integrated care and I'm writing down every single thing that the patient said, and I'm saying this patient's extremely neurotic, they're crazy, they're off their rocker, you know, that kind of thing, that's what should not be included in a medical record because it's extremely sensitive. They say everything else can, and it includes functional status, it includes symptoms, which I think you can put down all the things that you gather, diagnosis, etc. It doesn't specifically say things like safety planning, you know, is your patient suicidal? But as a psychologist, I have to include that. So it's still not, it doesn't help me sleep well at night to define a note exactly like what they say you can include. But at least it says something.
We're running out of time. Okay, I'm sorry. We're just running out of time. We got one more question.
So the bottom line question was, I think we still need to move towards having some way in the state of having policy, not state policy, but helping guide how people can better set up policies in their practices to protect themselves around this.
I appreciate your mission.
Thanks, Lori. So yeah, so I'll just say very quickly, you are not alone. So there are many people who have that sense that it is very gray, and you don't want to go to court to figure out whether you crossed the line, and you want to do the right thing. So I have talked with folks at the Office of Behavioral Health. I've talked with folks at Healthcare Policy and Finance, who oversees the Medicaid program. They are all very interested in seeing if they can provide clearer guidance on that. I don't have much to help you with except to point you back to HIPAA, unfortunately. But what you're pointing to is an issue for so many people.
We've got one more question online, and then we'll have to move to our next presenter. So from Kendra Mulch, please clarify the difference between those patients receiving services through the BHO, mostly Medicaid, versus those seeing providers outside of the BHO.
In terms of regulation, in terms of how they're covered?
This may have been a question for Paul.
Yeah, I'm thinking that might have been a question for Paul, because I'm not sure that has...
We'll go ahead and clarify that after.
Okay, and get that. Yeah. Is there time for one more in the back, or do we need to? Okay. Okay.
So I have my own theories as to probably why they're not a part of this. But you also said that there's about 10 more, so there's 11 total. What's kind of the holdup for the other hospitals?
The other hospitals are the what do they call them? They're the ones that are the safety net hospitals that have like critical access hospitals, and they have very little funding for this. And so we're working on trying to get funding. All the major hospitals are on. It's the critical access hospitals in the rural areas that haven't found the funding to be able to do the lift to get on. Also, in small rural areas, they're like, I just fax Joe over at whatever. Like, I don't need Corio. Like, you know, my referral range is like, I walk the piece of paper across the hallway. Like, what's the problem? So it's also that in rural areas, there's a smaller number of providers. Thank you very much. And my contact information is up there. If I can be of any help, answer any questions, please let me know. Thank you.
Thank you so much. I mentioned that we're going to hear about a few of the programs we have that we're kind of trying to address some of those problems that have already been mentioned. We're going to have Kim Cassidy from our CPAC program talk about that program, and Sheba Ibidumuni Dooney, to talk about another program we have called IESO, which is a sort of a texting therapy program. If we can get those CPAC slides up, and I'm going to introduce Kim Cassidy.
Hi, everybody. My name is Kim Cassidy. I'm a licensed clinical social worker and the supervisor of the CPAC program. We're going to get our slides up in here just a minute, but CPAC is actually an acronym for Colorado Psychiatric Access and Consultation for Kids program. That's why we call it CPAC. So it is a program administered by Beacon Health Options and actually currently funded by Colorado Health Partnerships. Okay, all right. So as Paul pointed out, that large crimson area, dark red area on his BHO map, Colorado Health Partnerships makes up 43 counties, and it's the largest BHO area. So we are currently funded by the 8 mental health centers that make up that area, as well as Beacon Health Options. So basically so I was going to bring actually the same map up and show you kind of what the situation in Colorado looks like as far as psychiatric providers, specifically child psychiatrists practicing in Colorado. Oh, here we go. So Colorado Health Partnerships actually is made up of a huge amount, as Paul pointed out, of rural and frontier area. And so that's why it's very important that CPAC is trying to fill the gaps in those areas. So if you look at this map, it's kind of hard to see, but at the bottom it shows how many child psychiatrists are actually practicing in those areas, and the blue is none. So there are no child psychiatrists in the blue areas, and even in the Denver metro, there could be as few as 20 practicing psychiatrists. So a lot of you probably know how difficult it is to get a child in to see a psychiatric prescriber. So this is what CPAC is trying to fill. So next slide. So in Colorado, it's estimated that up to 20% of kids have some sort of mental health issue. And as we just saw, there are very few practicing child psychiatrists. So what happens? They end up in the primary care offices and present with this behavioral health issue, and the primary care doctors are left with treating them. And then the next slide. So how does CPAC help address this issue? So CPAC is a service to primary care, and we actually enroll. We have 67 practices enrolled right now, and the primary component of CPAC is the psychiatric consultation. We have four child psychiatrists on retainer in our program. They are on call for us Monday through Friday, 8 to 5, and for those enrolled practices that we have, any prescriber in that practice can call the CPAC hotline. It's a toll-free number, and be connected with a child psychiatrist for a curbside consultation. So we administer this program regardless of insurance. It's not just for Medicaid members. The providers don't have to rummage through the chart and find out, is it Medicaid, is it not? They just pick up the phone, and we have somebody answering that phone, a live person, like I said, Monday through Friday, 8 to 5, that can then connect with them with one of our psychiatrists. So they'll do a usually 10, 15-minute consult on the phone. There's no PHI exchange. It is just a consult. What do I do with this child? 8-year-old, ADHD. We've tried every medication that I'm comfortable with. What's the next step? So that they can kind of get some guidance and some feedback, because really there's nowhere else to refer them out to. And if there is somewhere, it's a 3-month wait to see a prescriber at the mental health center or wherever they can go. So that is the primary component. And again, the goal is to fulfill and try to support the primary care doctors because of the lack of child psychiatry. The second component is care connection. If it is truly, in fact, an issue that cannot be handled in the primary care office, or it's very complex, our psychiatrists will sometimes say, wow, this is way complex and over your head, you probably should refer them out. So we can try to help facilitate that process. We have relationships with all of the mental health centers in the service area that we have, so we can try to make that process as easy for the family as possible. We often talk with the families directly to find out what exactly their needs are and try to do a warm handoff to those community providers. And we can do that for both mental or counseling services or prescribing services. So that is the second component. And then finally, we do a lot of educating and training of the offices. We often take our psychiatrists to the primary care offices to do lunch and learns or answer specific questions if they have a topic, if they want to learn more about children within bipolar in children. We can do a lot of educating and training. We are in the process of putting together some WebEx services for the more rural areas. It's hard for most of our psychiatrists have full-time jobs, have outpatient practices, and it's difficult for them to take 2 or 3 days to travel to Durango to do a lunch and learn. But so we're in the process of piloting a WebEx system that we can do some trainings with. So those are the components. And then just one last thing on that, the referral process. Part of what we intend to do is to work with whatever counselor or therapist we have them connected with. We always encourage them to report back to the primary care doctor, sort of this information exchange that's really important to know since the child was coming and referred from the primary care doctor, that they're also giving the information back to primary care. Okay, thank you. Next slide. So this is actually the CPAC service area. This is Colorado Health Partnerships that was read in the other slide, and the 8 mental health centers that are help funding us right now. So we've just recently expanded to the West Slope. A lot of our new practices are in that part of the state. We do still have some availability to enroll new practices. We do have to have them enrolled. We have an MOU and a BAA that we have them sign with us. So if anyone is in any of these counties and feel like you know of a practice who could benefit from CPAC and a child consultation service, it's totally free of charge for primary care and their families because of this funding that we have. So see me after. There's some brochures out in the lobby that have my contact information on them as well. So we also have a website that I didn't put on here, but it's cpac.org, cpack.org, and it has a lot of good information on there as well. Yes.
We have a couple questions from, I'm sorry, are you?
Sure, yeah.
We have a couple questions from online. One is this CPAC service only for primary care, or can public health use the service as well? Especially in frontier regions where public health provides umbrella services to the full community, it would be very useful.
That is a good question. So the way that we are structured right now, it's only for primary care.
The second question is this for only physicians or doctors, or can PAs and NPs access the service?
Any prescriber in the practice can use the service. Definitely. We encourage it. Actually, any staff person in the enrolled practice can call. For example, if a child, maybe if a family wants to try counseling first and doesn't know where to start, They can call us. Anybody in the practice, the front office staff can call and say, hey, this family is ready to get into some counseling. We always offer at least 2 or 3 options to the family. We obviously don't want to choose for them. So according to their insurance and area of town and issues, we have a whole database, and it's growing, obviously, as we grow across the state. But we have a database of therapists and counselors and agencies that deal, what ages do they see, what specialties do they have, what insurances do they take. And so we give families options. We also do a very warm handoff in that we will call those therapists first to make sure that they have availability, that they feel comfortable treating those issues. And so families don't have to, we found that if a family has to call 5, 6, 7, 8 people and hear, no, I'm not taking a new patient, no, I don't take that insurance, then they're going to give up. So we try to make it really simple and say, here's some options. We know they have availability. Call, make sure you're comfortable, and ask your own questions, have a conversation, those kind of things. Yes.
What is the response time for the consulting psychiatrist?
Thank you for asking that. I should have said. We have, our goal is to have them call back to primary care within 30 minutes. Yes. If that doesn't work for them, if they want to call in the morning and say, hey, I have a lunch break at 11:30, can somebody call me then? We can do that as well. But our goal is really, even if the child is there in the practice, and the family is waiting, then we try to have that 30-minute callback time. Okay. Yes.
Another question. We've worked with CPAC for the last 3 years, and every pediatric practice or family practice we've hooked up with them, they absolutely love them. The response time is exactly what Tim is telling you. They get patients in within 2 days.
Oh, sorry. They get patients in in 2 days, and prescribers feel a lot more comfortable if somebody has to go on a wait list. So thank you guys for what you do. We love you.
Yes, thank you for saying that. Yes. Good question. So if you go back to the map, please. In the Center for Mental Health area, we actually are piloting. The Center for Mental Health has actually funded an adult program. So that's this red area here, that those practices that are enrolled can call at any age. So we have a different set, and some of them do both, but some psychiatrists that they can call. That one's called PsychLine. And that is an adult program that hopefully we can expand to the rest of the counties as well. Yes, thank you.
Thank you, Kim. And if we can bring the IESO slides up, and we're going to have Sheba talk to us a little bit about another innovative program we have that has to do with texting therapy. And I'm going to let Sheba do the explanation of that.
Good morning. My name is Sheba Ibiduni. I think as we bring up the slides, I'll just give a little background about myself. So I used to work for the Healthcare Policy and Financing, the state Medicaid agency, and also worked at Colorado Access with the RICOs and did integrated care work. So I think I know some of you guys in the room. So now I work for IESO Digital Health. We are new to the US. We are a company that's based in the United Kingdom, and we partnered with Beacon Health Options. And so the program I'll be describing here in Colorado is our first entry into the US market. Next slide. So a little bit about what we do. We do online cognitive behavioral therapy. There is no audio or visual component. It is instant messaging is the easiest way to describe it. We have a platform that we've built. It is secure and HIPAA compliant. Patients can schedule appointment times at any time of day with a licensed and credentialed therapist. And they log into the platform, and the therapist is there waiting for them, and they begin their session. And it's strictly cognitive behavioral therapy. That's the only type of therapy we provide. And we're only treating anxiety and depression at the moment. So we're just starting with CBT for conditions that are evidence-based that CBT is effective in treating. Next slide. So in terms of what the IESO advantage is, Paul and Kim talked about the challenges facing the rural frontier areas. Digital health, telehealth is kind of blowing up recently, and there's a lot of reasons for that. Access is one of them. So when you think of these rural and frontier areas where transportation, especially when we look at the Medicaid population, transportation is a challenge. Finding a ride, getting a ride, traveling miles to get to a provider who, if you're lucky, is accepting new patients in the area is also difficult. With what we're providing, with the digital health that we're providing, all you need is an internet connection and an internet-enabled device, so computer, smartphone, tablet. I do get that in the frontier areas, internet can be a bit spotty, and not everybody may have internet in their homes, but since there is no audio or visual component, there's an added layer of privacy. So you can go to a coffee shop that might be offering free Wi-Fi. You can go to a public library. We will even, what we've entertained, we haven't done this yet, but we can work with primary care providers if they have extra space to put devices in the primary care office, and so people can access the service at another location outside their home if they want as well. In terms of productivity, so our licensed and credentialed therapists, there is a fairly rigorous training and clinical supervision program that we provide. And we also provide continuing professional development. So supervision is mandatory. There is no therapist that works with us that does not have a clinical supervisor that they do not meet with. So they meet with their supervisor regularly. All of the sessions, we do have clinical transcripts available from the sessions, and they use that in their supervision. So we can actually go through, and I shouldn't say like everybody in the company has access to this, it's really just the therapist, the patient, and the supervisor who can go through those transcripts and use it to reinforce the clinical protocols that our therapists are supposed to follow as they provide CBT. The patient also has access to these to the transcripts, and so they can use them in between sessions. The patient's also able to message the therapist in between sessions as well. So you can stay more connected to your therapist at the same time. And then quality. So we do collect quite a bit of data as we go through and provide the service. So I'll explain this a little bit more when I go over the patient pathway, but during registration, the patient completes 5 questionnaires. The PHQ-9 GAD-7 are required. There's a self-assessment, a risk assessment, and a substance use disorder assessment. And then at each scheduled appointment, the patient also completes another GAD-7 and a PHQ-9. So we're able to track their how they're performing and how they're progressing throughout the course of their treatment, measuring their scores from the PHQ-9 and the GAD-7. So we're able to identify a rate of improvement for patients with their beginning scores and their end scores as well. So in terms of CBT, this slide describes what CBT is. Nuts and bolts, it's short-term goal-oriented therapy that helps people understand the behaviors and how they're reacting to certain situations. And so when I say short-term, this isn't ongoing long-term treatment. You're not going to an office and laying on a couch and just talking. We talk, but it's very specific. And there's homework and goals that the therapist and the patient work on throughout their course of treatment. If someone does need higher level services or wants to do face-to-face or wants to do long-term therapy, we work with Colorado Health Partnerships to refer them to a provider who can provide that for them. Next slide. So in terms of who is suitable, right now we're working with adults only, so age 18 and older. You do need access to internet and have an internet-enabled device, as I previously mentioned. We're treating depression, including postpartum and /or anxiety. We also are able to treat OCD and PTSD. So those are the 2 other conditions that have cropped up since we launched in Colorado as well. Rural and remote is ideal. Anybody who's experiencing stigma, so if you don't want to go and be seen at a therapist's office. Part of what I've heard also in like small towns is people recognize the car that you're driving, and if there's one therapist office in town and they see your car in the parking lot, then you might not have told them, but they know you're there for a reason. People with busy schedules, and I also put in here a caregiver, so that could be an adult caregiver, adult children looking after their parents, or someone who has a young child, or someone who's just dependent. And then when you think of busy schedules, I think of working adults, single parents, that kind of stuff. Because our appointment times are flexible, you can squeeze in therapy into your day. Our more popular times are in the evening, so between 6 and 10, and on the weekends. So during that patient registration process, we screen for people who are in crisis or experiencing active psychosis, and this is not a modality that's suitable for them, so we will work with Colorado Health Partnerships to get them tucked into appropriate services. And we are not treating people with active substance use either at the moment. Next slide. So in terms of the care pathway, we work off of self-referral. We do try to educate providers, primary care as well, about this resource that's out here, but we also have a patient outreach campaign. So we send SMS text messages to individuals, letting them know that this is a new and free service available to them as part of their Medicaid benefit. They can go to IESOhealth.com where they can register for the service and fill in those 5 questionnaires I mentioned. Our clinical director does a suitability assessment to review those assessments that they've completed to make sure that they are suitable for online CBT. If they are suitable, then they're matched with a therapist, and the therapist is identified based on like availability, as well as someone who has, through supervision, has proven themselves to be pretty effective in treating whatever condition that patient is presenting with. In that first appointment, that's the assessment. The therapist meets with the patient for an hour. They identify the issues that the patient is facing. They step the patient, so that's looking at the severity. So we have step 2, step 3, and step 3+. In the Medicaid population, we've seen more step 3 and 3+, so those are moderate to severe conditions. And then they also work on a treatment plan. Sure. And then the STEPS care model. So this is a model that is evidence-based and is out of the UK, and it's endorsed by NICE. And so basically it identifies the different steps you might have with the patient. So step 1 is the least acute, and that's recognition in primary care and general hospital setting. Step 2 is treatment of mild depression in primary care. Step 3 is treatment of moderate to severe depression. Step 4 is treatment of depression by mental health specialists, and step 5 is inpatient treatment for depression. So as I mentioned, we're really focusing on step 2 and step 3. Step 4 and 5 would be those services that most likely would need authorization from Beacon Health Options and CHP. Next slide. So in terms of who provides the service, as I mentioned earlier, all of our clinicians are licensed here in Colorado and credentialed by Beacon Health Options. We do train them in CBT if they don't already have that training. We've found that there are slight differences between the UK and the US. The UK does have an accreditation program for CBT, and we don't have that in the US. So we are developing our own training module so that all of our clinicians have the same proficiency level. Next slide. So in terms of patient profile, the diagnoses we're seeing: major depressive disorder, general anxiety disorder, adjustment disorder. We do get more females than males. So right now we're at 81% female, 18% male. Contract year to date, we've done 192 assessments, 132 people have entered treatment, 47 people are eligible for success evaluation. So these are people who have completed treatment and have a beginning score that can be compared to their final scores on the clinical validated tools. And then the rate of improvement is 61%. So of the 47 who were eligible for success evaluation, 61% of the people improved. And the rate of improvement is measured according to the statistical reliability of those clinical validated tools. Next slide. So in terms of patient feedback, this is from one of our earlier patients in the IESO program here in Colorado. Why did you choose online therapy rather than face-to-face therapy? They said they didn't have to travel, they can open up more online, and they couldn't leave the house easily. That second bullet point is important. There is a theory that's called the online disinhibition effect, which says that people are more able to open up and be more candid and more free without having to see somebody. There's that added protective layer of a screen. And so we tend to get a lot more raw and more therapy done because there also isn't a lot of distractions. You don't have to spend a lot of time with niceties and talking about things that perhaps aren't very germane to the actual appointment. How did you find using the therapy website? They felt it was very easy. And then about their experience, they felt confident opening up as well as trusting the advice their therapist gave, great appointment times to meet their schedule and personal needs. And it was great knowing they could message a question, concern, or update anytime without an appointment. And therapists are able, well, we ask that they respond to these non-urgent messages within 48 hours. And I think that's it. Yeah? Okay, questions? Sure. So the question was, how quickly can patients re-enter the program after they complete treatment? If it's a new episode of care, they can come back into the program. We'll just have them work with the supervisor to determine that it is a new episode of care. For the same episode of care, if nothing has changed, we typically ask that they wait about 8 weeks. But if there's an issue, I mean, if someone's like, no, I really need to talk to you, we will work with them. Well, so that's also part of the reason why we do ask that they wait for 8 weeks. But we do have crisis plans and crisis management in place. So the issue there is just making sure whether this is a crisis or if this is somebody who enjoys, because we do have some patients who get a bit anxious at the end of treatment and they're like, well, can I keep in touch with you and just talk with you from like week to week? Typically we say no. We've set the goals, we've given you discharge instructions, keep practicing on that and come back to us if things aren't going well. But we don't want to be in a position where we're just providing therapy with no end in sight, just because that doesn't match the CBT model. Oh. So we are under a administrative arrangement.
Can you repeat the question?
Oh, so the question was, how are we reimbursed? Is it fee-for-service, capitated, or a subcapitated arrangement? And we are actually reimbursed through administrative funds paid for by the 8 mental health centers that participate with CHP. On a case rate basis, yeah. And so the case rate, there is a value-based component in that as well. So we're paid for treatments, and then we're also paid for a success component. So the final payment we don't receive if patients haven't improved. Yeah. Good question. So the question was, what languages are available? As this is written conversation, right now, the only language that's available is English, but we do have plans to expand to Spanish. There's a bit more added layer of difficulty because written fluency is a little different than verbal fluency. And so we need to ensure that the providers we're recruiting are fluent in the written language as well.
What's the definition of short term?
So short term, it depends on the step that they're assigned. And so these are just recommendations. We don't cut people off if they need more therapy. So step 2, which is more mild, I think the ideal treatment length for there is 4 to 6 sessions. Step 3, mild to moderate, is between 6 and 8 sessions, and then step 3 plus for moderate to severe, we've seen run anywhere from like 8 to 12 sessions.
61% that experience improvement. Can you quantify that? How does it compare to people that see control group?
So the question was, can I quantify the people who have improved, and how does it compare to a control group where the control is individuals receiving face-to-face CBT? In the US, I don't have that particular data, but in the UK, we do have that data. So for online CBT delivered by IESO to our patients, we have seen improvement rates in the UK of 51%. And that's still using those scores on either the GAD-7 or the PHQ-9. Compared to face-to-face CBT provided to NHS as a whole patients in the UK, those improvement rates were 45%. So, and there was also a randomized controlled trial that was published in 2009 in The Lancet, a UK medical journal that reviewed the protocols we use, the methodologies we use, that also identified those 2 figures to show that online CBT is as effective as face-to-face CBT and perhaps slightly better in terms of recovery or improvement rates. I'll go here and then to you.
I don't get the disease assessment and treatment. That's quantified. I expect it to be evaluation. What about the eligible versus staff evaluation? Out of 132 that are in treatment, only 47 have the eligible versus staff evaluation.
Yeah, so.
And then 61% of the 47
correct.
are actually showing some.
Sure. So let me explain this a little bit more. So we've done assessments on 192 people. Entered treatment means 132 people have received at least 1 assessment and 1 therapy visit. The 47 who are eligible for success have had, by definition, have to have had at least 2 therapy visits and then have completed treatment as well. So these, it's not a clean of, they're not like, how would I explain this? So this 132 is a part of the 192, but the 47 is a component of 132, but that doesn't include people who are still in active treatment. So there are still people who are still in treatment, and we've had people who are taking longer. So on average, you would think people could get through our treatment in about 8 weeks, but people miss appointments, and then we have to follow up and get them rescheduled. And we didn't really start our patient outreach until about October. So we have a lot of people who are still in the pipeline waiting to complete their treatment. So there is a lag in the numbers. And so I was just reporting them as they are. But there is, like right now, we have about 150 people who are still in active treatment. And this eligible for success evaluation has actually climbed to 65. Yeah.
No, there's just 2 minutes left. Okay, I just had a quick question. So basically, people would get in touch with you through contacting their behavioral health organization, like the phone number is on this resource page, and then that they would then refer them to you. Well, I guess I'm just trying to figure out like kind of the path.
Yeah, so there's a few different pathways. I mean, they could hear about us from primary care, they could hear about us from the BHO, they could even hear about us from CPAC. There's a few different ways that they can find out. They can also hear about us directly from IESO with the text messages. All they need though is just our website, and then they go to the website and they click patient login, and then they create their account or their profile and start the registration that way. No. Okay. No, because this is part of those services that Paul talked about that don't require authorization. Because so take the online component away, it would be as if it was just face-to-face therapy that you were getting from another therapist. No, it does.
So for some reason, if they call and do the assessment and it's not going to get treated, then what happens?
So then we work with Colorado Health Partnerships to get them tucked in to a provider that can address their needs. It's a little bit of both. It depends a little bit on the situation. We have the ability to do warm handoffs. It'd be more of like a let me dial the number and then transfer you, or we can just provide them with the phone number and say Colorado Health Partnerships is your behavioral health provider. They can help connect you to a. No, we are not currently tracking the referrals. No, I mean I could. That's under my purview as operations. So yeah, that's a great idea. We do track. So I should have said this, we only do Medicaid only. So if we have dual diagnoses, we aren't able to treat them. So we do keep track of people who come to us with other forms of insurance. Okay, thanks.
Thank you.
All right, everyone, thank you so much. We are planning to have these events quarterly, and I'll be sending out an evaluation probably later this afternoon or tomorrow morning. Please, please, please give your honest feedback. This is the pilot, as you can see by the technological issues, but I think I have them all worked out, so it should be a little smoother. And thank you for coming.